Welcome to the deep dive. Today, we're tackling a real cornerstone of modern medicine, computed tomography, or CT scans, as most people know them.
That's right.
And for you, our listener, thinking ahead to your medical training, really getting a handle on CT is, well, it's going to be absolutely essential for how you'll approach diagnosis and patient care down the line.
Absolutely. We've pulled together quite a bit of material for this. Insights from medical websites, some key bits from medical textbook, and a pretty detailed overview from Wikipedia, too.
Okay.
Our mission today really is to give you a solid foundation. We want to cover what CT scans are, the mechanics, how they actually produce those images. There are many, many clinical uses.
Right.
Their strengths, weaknesses, especially compared to other imaging, and importantly, the ethical side of things. Those considerations that will definitely shape how you use this tech in your future practice.
All right, let's dive in then. What exactly is a CT scan in practical terms?
Well, in essence, a CT scan is a pretty sophisticated medical imaging technique. It gives you really detailed cross-sectional views, pictures inside the body.
Much more than a standard X-ray, I gather.
Oh, much more clarity, yes. Think of it like that. You might also hear the older term CT scan. That stood for computed axial tomography, or sometimes just X-ray CT.
Okay.
They all mean the same thing, basically. And it's worth remembering, these scans aren't done by just anyone. They're performed by skilled professionals, radiographers, or radiology technologists.
And this tech, it wasn't always here. It has a significant history, right?
Oh, absolutely. The development of CT scanning was genuinely groundbreaking for medicine. It was even recognized with a Nobel Prize back in '79 in physiology or medicine.
Wow.
Yeah, it really highlights the innovative thinking behind it.
So we know it gives these detailed internal images, but how does it actually do that? It sounds more complex than just snapping an X-ray picture.
It is, precisely. While CT scans do use X-rays, the whole process is significantly more intricate. So during the scan, you have an X-ray tube rotating around the patient.
Okay.
And it's emitting this thin, kind of fan-shaped beam of X-rays. On the opposite side, there are detectors, and these measure how much X-ray radiation actually passes through the patient's body.
Ah, so different tissues block the X-rays differently. Bone versus muscle, for instance.
Exactly. Different tissues absorb or attenuate these X-rays to varying degrees. That's the key.
Okay, so it's measuring how much that X-ray beam is weakened as it goes through stuff.
You got it. Now, this raw data that the detectors collect, all these measurements from tons of different angles as the tube spins around, that needs to be turned into an image we can actually understand.
Right, the computed part of computed tomography.
Precisely. This is where powerful computer algorithms come in. They take all that attenuation data and perform something called tomographic reconstruction. It's a complex mathematical process, really, that creates those detailed cross-sectional images. We often call them slices.
Slices. So when we look at a CT image, it's like we're seeing a virtual slice through the body, kind of like slicing a loaf of bread to see the inside.
That's an excellent way to think about it, yeah.
Yeah.
Each 2D scan is like one thin cross-section. The initial sort of raw data can also be shown in this complex graph called a sinogram, but
Yeah.
honestly.
The important part for me as a future doctor is the final image.
Exactly. The crucial step is the computer processing all that info to generate the diagnostic images you'll be looking at and relying on in your practice.
Okay, that makes sense. Now, as a future doctor, I know I'll constantly be weighing up which imaging test is best for a particular patient, a particular situation. How does CT stack up against other common ones, like, say, MRI and PT scans?
That's a vital question and one you'll grapple with often. Let's start with MRI, magnetic resonance imaging. Now, visually, for the patient, CT and MRI can seem similar. You're lying on a moving table going into a big donut-shaped machine.
Right.
But how they make the images is fundamentally different. CT, as we've said, uses X-rays. MRI, on the other hand, uses radio waves inside a really strong magnetic field.
So different energy forms create the picture. What does that mean for what each scan is best at actually showing us?
Well, CT generally excels at showing the location and boundaries of structures really clearly, like where exactly does this organ end and the next one begin. It's especially good for dense stuff like bone.
So fractures.
Perfect for fractures, yeah. Also internal bleeding, blood clots, injuries to the spine, brain injuries. CT is often the first choice there.
Okay. And MRI.
MRI tends to give superior detail when you're looking at soft tissues. It's better at differentiating between normal tissue and abnormal tissue.
Ah, so things like ligament tears or problems inside organs.
Exactly. Ligament, tendon injuries, issues within the heart, brain, digestive organs. MRI often gives a clearer picture there.
Yeah.
And also, for certain types of cancer, uterine, prostate, some liver cancers, MRI can sometimes show them more distinctly than CT might.
And there are practical things too, aren't there? I seem to remember something about metal implants.
Yes, that's a very important point to lock away for your future patients. CT scans are generally safe if someone has metallic implants or, say, a pacemaker.
But MRI isn't.
Well, the strong magnetic fields in MRI can be a serious safety risk for those patients. It often means MRI is contraindicated. You just can't do it.
Okay, that's a critical difference to remember,
Sure.
definitely. Now, what about PET scans, positron emission tomography? How do they compare?
PET scans also give us images of organs and tissues, but they work in a totally different way again. With a PET scan, the patient gets a small, safe dose of a radioactive tracer, a radio tracer,
Okay.
and areas in the body that are more metabolically active working harder essentially will absorb more of this tracer. The PET scanner then detects where this increased activity is happening.
So P isn't just about structure, it's about function, cellular activity.
Precisely. It's looking at physiology. PT can often detect changes at the cellular level, sometimes even before you'd see a structural change on a CT or MRI. It gives insights into things like blood flow, how tissues are using oxygen, glucose metabolism.
So it might find problems earlier.
It potentially can, yes. It might identify malfunctioning organs or tissues earlier than a CT could spot a physical change. The trade-off is that the PT scan procedure usually takes longer, often around 2 hours or so. You need to give that tracer time to travel through the body and get absorbed.
Okay, so summarizing that for myself. CT for structure, location, bone, urgent stuff. MRI for amazing soft tissue detail. And PET for function, for metabolic activity. That's a really helpful framework as I think about making those diagnostic choices later on.
That's a great way to frame it.
Now let's dig a bit deeper into the specific medical uses of CT. What kinds of things will I, as a future doctor, be using CT scans to look for most often?
Oh, the applications are incredibly broad. Let's start at the top with the
Yeah.
head. CT is absolutely indispensable for quickly diagnosing strokes, finding tumors, identifying calcifications, hemorrhage that's bleeding,
Right.
and assessing bone trauma, like skull fractures. You'll hear terms like hypodense. That means darker areas on the scan, which could be fluid or less dense tissue, like in certain strokes, and hyperdense, brighter areas, often meaning denser stuff like bone, calcifications, or even fresh blood.
Okay, hypodense, dark. Hyperdense, bright. Got it.
And head CTs are also vital for guiding certain procedures like CT-guided stereotactic surgery or radiosurgery for treating problems inside the skull.
And moving down the body, what about the neck?
In the neck, CT is really valuable for checking out neck masses and also for imaging the thyroid gland to look for any abnormalities there.
Lungs. I imagine CT is big there.
Huge,
Mm-hmm.
especially high-resolution CT for the lungs. It's a key tool for detecting lung cancer, obviously, but also for seeing things like thickened bronchial walls, which might point to inflammation, finding those incidental pulmonary nodules.
Ah, yes, the unexpected little spots.
Exactly. And this is really important, especially for you going forward. Be aware of the guidelines around managing these. Just finding a small nodule doesn't always mean endless follow-up scans.
Why is that?
Well, because of the radiation. Extensive CT surveillance, especially if the patient has no cancer history and the nodule isn't growing over, say, 2 years, is generally discouraged. You have to balance finding something early against the cumulative radiation risk.
That balance, finding things versus potential harm from the test itself. That seems like a recurring theme I'll need to navigate.
It's absolutely central to good practice. CT is also fundamental for angiography, using contrast dye to visualize blood vessels anywhere in the body, and for specific heart checks, like cardiac CT angiography.
Okay.
Then in the abdomen and pelvis, CT is just used for a massive range of conditions.
Yeah.
And for the axial skeleton, the spine, basically, and the extremities, arms and legs, it's excellent for getting detailed views of bone structure and injuries.
You've mentioned cancer detection a few times now. Can we focus on that specifically? How exactly does CT help in the context of oncology?
Right. CT scans are really integral to almost every stage of cancer care. They can be crucial for initially finding a tumor in the first place. Then, they provide vital information for staging the cancer, figuring out how far it has spread.
Staging determines the treatment, often.
Exactly. CT also plays a key role in guiding biopsies, helping us get a tissue sample from exactly the right spot. And after treatment starts, CTs are used to monitor, are there signs of the cancer coming back? How well is the treatment actually working?
And are there specific cancers CT is particularly good at finding?
Yes, some cancers are often detected well with CT. Things like colorectal cancer using a technique called CT colonography, lung cancer, definitely, and cancers of the bladder, kidneys, ovaries, stomach, and pancreas.
So it really is a workhorse tool throughout the whole cancer journey, from finding it to following up. You mentioned contrast agents again with angiography. Can we talk a bit more about those? What are they and why use them?
Sure. Contrast materials, or radiocontrast, are substances we give to the patient, usually intravenously into a vein, and they're typically iodine-based.
Iodine, guys, okay.
Their main job is to make certain structures show up much more clearly on the CT scan. Blood vessels are a prime example. They can also give us information about how different tissues are functioning, in a way.
And sometimes people drink something before a scan.
Yes, exactly. For looking at the gut, the gastrointestinal tract, we often use barium sulfate as an oral contrast agent. You drink it, it helps outline the internal organs, the stomach, the intestines, and it usually passes out of your system within about 24 hours.
So that's the chalky drink people talk about sometimes.
That's often the one, yes.
Mm.
Depending on the scan, there might be other prep too. And after getting intravenous contrast, the stuff in the vein, it's standard advice to drink plenty of fluids. Helps your kidneys flush the contrast out.
Are there any downsides, risks with these contrast agents?
Yes, there are potential side effects we need to be aware of. The most common ones are usually mild. Maybe some itching, a rash, feeling a bit nauseous, maybe vomiting, headaches, dizziness, stuff like that.
Okay, generally mild.
Generally. But in rare cases, more severe, even life-threatening allergic reactions can happen. That's why patients are usually watched for a little while right after getting the contrast.
So checking for allergies beforehand is critical.
Absolutely crucial.
Yeah.
You have to ask about allergies to medications, seafood, iodine itself before giving contrast. There's also a known risk called contrast-induced nephropathy.
Nephropathy, kidney damage.
Kidney injury, yes. It's a particular concern for patients who already have kidney problems or diabetes or might be dehydrated. So in those folks, we often use special hydration protocols. And we have to be really cautious about using contrast at all if their kidney function is already moderately low.
Right, so it's always that risk-benefit calculation again. Does the extra information from the contrast outweigh the potential risks for this specific patient?
That's exactly the thought process you need to have.
Okay, let's broaden that out then. Thinking about the CT scan itself, not just the contrast, we touched on radiation earlier. Can we unpack that risk a bit more? It feels like a major consideration.
It is. You're absolutely right. Radiation is a crucial factor. CT scans use ionizing radiation, and we know that this type of radiation can damage DNA. And theoretically, that increases the long-term risk of developing cancer.
But how big is that risk, really?
Well, it's important to keep it in perspective. The individual risk from a single, properly done CT scan is generally thought to be low. Maybe in the ballpark of 1 in 2,000 chance of a fatal cancer from one scan, roughly speaking.
But like we said with those lung nodules, it's the cumulative effect over a lifetime that's the bigger worry.
Precisely. That's where the main concern lies. The risk adds up with each CT scan someone has, and this is especially true for children.
Why children specifically?
Two main reasons. One, they're still growing. Their cells are dividing more rapidly, which might make them more sensitive to radiation damage. And two, they simply have a longer lifespan ahead of them for any potential effects to show up.
So we need to be extra careful with kids. Lower doses.
Absolutely. It's standard practice now, or it should be, to adjust the CT machine settings, specifically for pediatric patients, to use the lowest possible dose that still gives a good image. All-or-all principle, as low as reasonably achievable.
And pregnant patients.
Similar caution there, especially if it's scanning the abdomen or pelvis. The developing fetus is very sensitive to radiation. So if possible, we try to use non-radiation alternatives like ultrasound or sometimes MRI.
Are the doses from CT much higher than regular x-rays? I always thought x-rays were low dose.
Generally, yes. CT doses are significantly higher, often, 100 to maybe even 1,000 times greater than a simple chest x-ray, for example. Though it's worth noting some complex x-ray series, like for the lumbar spine, can actually have a dose comparable to a head CT.
Okay.
And other complexity doses can vary quite a bit, even for the same type of CT scan. Different machines, different hospitals, different protocols can mean different radiation doses. It's not uniform.
Have studies actually linked CT scans to increased cancer rates?
Yes, large epidemiological studies have shown a correlation. Exposure to low-dose radiation, like from CT scans, is associated with a slightly increased incidence of various cancers later in life. Some research, for instance, points to a small, increased risk of brain tumors linked to CT scans, especially in childhood.
And obviously worse for people needing lots of scans.
Right. The risk is inherently higher for patients undergoing repeated CT scans over many years. And as we mentioned, younger people generally face a higher lifetime risk from the same dose compared to older adults, simply because they have more years ahead for a cancer to potentially develop.
Has anything ever gone wrong with the doses?
Tragically, yes. There have been documented incidents where, due to incorrect machine settings or errors, patients received excessively high radiation doses, causing direct harm like hair loss or skin burns. It really underscores how critical strict quality assurance and safety checks are in every imaging department.
Should patients be told about these risks?
Well, current best practice recommendations generally say yes. Patients should be informed about the risks, especially the radiation aspect, as part of the consent process. But honestly, it doesn't always happen unless the patient specifically asks.
That's something I need to remember my responsibility to inform patients properly. These are crucial points as I think about ordering scans in the future, always weighing that benefit against these potential long-term
That's
harms.
a constant balancing act.
And what about the contrast reaction risks we talked about? Just to recap those quickly.
Right, so mild reactions, nausea, vomiting, maybe an itchy rash. Those are the most common things you might see.
But severe ones are rare.
Severe, life-threatening reactions like anaphylaxis are rare, yes. Especially with the newer non-ionic contrast agents we tend to use now, which are safer than the older ionic ones.
That's still possible.
It's still a small possibility, yes. Anaphylaxis and even death can occur, though it's very infrequent. The risk might be slightly higher in females, the elderly, or people who are already in poor health. And again, that risk of contrast-induced nephropathy, the kidney injury, especially in patients with existing kidney problems, always need to check kidney function first.
Okay, so it's a double consideration. Radiation risk from the scan itself and potential contrast reaction or kidney risk if contrast is used. Now, once we have the images, how are they actually read? And what can affect how good they look?
Good questions. The images themselves are usually grayscale. Different tissues show up as different shades of gray based on how much they attenuated the X-rays, basically their density.
Right.
Radiologists then use something called windowing. It's like adjusting the brightness and contrast on your TV, but much more sophisticated. They adjust the window levels to best visualize specific things, bone, soft tissue, lungs, whatever they need to focus on.
And can they look at the images in different ways, not just those flat slices?
Oh yes. They routinely use multiplanar reconstruction, or MPR. That takes the original axial, slices the loaf of bread slices, and reconstructs them into different planes, like looking from the side, sagittal, or from the front, coronal. And they can even do volume rendering to create 3D visualizations.
That 3D view must be really helpful for understanding complex anatomy, like before surgery.
Hugely helpful, yes. For surgical planning, understanding tumor relationships, vascular anatomy, it's very powerful.
What about image quality? Are the pictures always perfect?
Not always. Image quality can be affected by a few things. And there's often that trade-off we mentioned between radiation dose and image quality. Sometimes getting a sharper, less noisy image might require a slightly higher dose.
And artifacts, things that mess up the picture.
Yes, artifacts are definitely something radiologists have to watch out for. They can sometimes hide or mimic pathology. There are several types. Motion artifacts, if the patient moves during the scan.
Makes sense.
Beam hardening artifacts, which happen because the X-ray beam isn't just one energy level. Metal artifacts from things like fillings or implants can cause big streaks. Partial volume effects can blur small details. Ring artifacts can happen if a detector isn't working perfectly.
So interpreting CTs isn't just knowing anatomy, it's also recognizing these potential glitches in the image.
Exactly. It's a highly specialized skill. And thankfully, there's ongoing work to reduce these artifacts, like using newer iterative reconstruction techniques, especially for metal.
Okay. Now, shifting gears a bit towards the practicalities and ethics. As a future doctor, I'll be the one ordering many of these scans. What are some of the really crucial things I need to keep in mind from an ethical or practical standpoint when I'm thinking about clicking that Order CT button?
This is such a vital area for you to really get your head around as you develop your clinical judgment. One really concerning thing that came up in the sources is that a significant chunk of requests for CT scans, especially chest, abdomen, pelvis, often lack complete clinical information.
What kind of information?
Things like, what is the patient's main symptom? Where exactly is it? How long has it been going on? And crucially, what do you, the referring doctor, suspect might be the cause?
Why is that so important for the radiologist?
Because that clinical context is absolutely essential for them to interpret the images accurately and provide a report that's actually useful to you and the patient. They need to know what question the scan is trying to answer. As the referring physician, it's really your responsibility to provide a thorough clinical history with every scan request.
So just writing rule out PE isn't enough. I need to give the background.
Ideally, yes. The more relevant clinical detail the radiologist has, the better they can tailor their search pattern and focus their interpretation. It helps them identify findings that are truly clinically significant for that patient's problem.
That makes sense. What other ethical considerations are there?
Another big one is around using CT for screening. Widespread screening of people without symptoms, especially when there isn't strong, solid evidence to prove it actually benefits people at a population level.
You mean like those full body scans you sometimes see advertised?
Exactly that kind of thing. We've seen CT screening tests marketed directly to consumers, and sometimes patients might even self-refer, asking for a scan without a specific medical reason.
I can see how that might lead to issues if the evidence isn't there to back it up.
Precisely. Doing scans without a clear indication, especially screening scans without proven benefit, has several potential downsides. There's the radiation exposure, obviously. There's a higher chance of finding false positives, things that look worrying but turn out to be nothing, leading to anxiety and maybe unnecessary invasive follow-up tests.
And finding things that don't matter.
Yes. The detection of pseudodisease or incidentalomas, finding things that look abnormal but would never actually cause the person any harm if left alone. While we absolutely respect patient autonomy and the desire for early detection, the main goal of a public health screening program has to be proven benefit, like reducing deaths from that specific disease. And for many CT screening applications, that high bar of evidence just hasn't been met yet.
So population screening needs really strong proof, like from big trials.
Ideally, yes. Randomized controlled trials are the gold standard. And endorsements from major professional bodies like the U.S. PSTF, the U.S. Preventive Services Task Force, who grade the evidence for screening tests.
And where does most CT screening stand right now, according to them?
Well, a lot of it currently falls into categories where the recommendation is either against routine screening, grade D, or where there's insufficient evidence to make a recommendation either way, grade I.
So as a physician, I should generally advise against screening CTs if there isn't strong evidence or a clear guideline recommending it for that patient group.
In general, yes. That's the evidence-based approach. Widespread use of unproven screening can actually hinder the research needed to figure out if it truly works or not. History has examples of tests or treatments that seemed like a good idea, but were later found to be ineffective or even harmful after proper study.
So even if a patient comes in asking for a specific screening CT they saw advertised, my job includes guiding them based on the evidence, even if that means saying, no, I don't think that's appropriate right now.
That's exactly right. It's about shared decision-making, explaining the pros and cons based on the best available science. Now, there might be complex gray areas, like lung cancer screening with CT in very high-risk smokers. The evidence there is still debated by some, balancing potential early detection benefits against the risks and costs of follow-up for nodules found. It's not always black and white.
Right.
But the principle remains. When population screening isn't clearly recommended, your individual decisions should weigh the evidence strength, the patient's specific risks, their values, and your own clinical judgment very carefully.
These are incredibly important ethical dimensions I'll need to keep front and center throughout my career. It's clearly not just about the cool technology, it's about using this powerful tool wisely and safely for my patients.
Couldn't have said it better myself. Understanding the tech is crucial, but it must be paired with sound clinical reasoning and a commitment to ethical, evidence-based practice.
Well, this has been a hugely valuable deep dive into the world of CT scans. Just to summarize the key takeaways for me and for our listeners, we've covered the basic physics of how CT works, its incredibly broad and vital uses in diagnosis, looking for things I know I'll see frequently as a doctor. We've also really nailed down the crucial differences between CT, MRI, and PET, knowing when each is likely the better choice.
Understanding those relative strengths and weaknesses is key.
Absolutely. And critically, we spent time on the really significant considerations around radiation risk, the use of contrast agents, the benefits and potential harms there, and these complex ethical implications that have to guide how I'll order and interpret these powerful scans in the future.
And for you, moving forward in your medical journey, the absolute bottom line is approaching CT, and really all advanced imaging, with thoughtful, evidence-based decision-making. Always asking, What is the potential benefit for this patient, and how does that weigh against the potential risks?
So the challenge for me, and I guess for every doctor starting out, is how do I balance the allure, the power of this amazing imaging technology like CT with those fundamental principles of patient safety, doing no harm, and sticking to evidence-based practice? That's definitely a crucial question to carry forward.
Thank you. This has been incredibly insightful.
My pleasure. It's essential knowledge to build on.